Welcome to today's webinar entitled TB and Tobacco Pharmacotherapy for Tobacco Cessation, sponsored by the Southeastern National TB Center. My name is Karen Simpson, Co-Executive Director at the SNTC, and I'm moderating today's webinar. Today's speaker is Kathy Cook. Kathy is currently the Lead Systems Change Coordinator for the Swanee River Area Health Education Center. She began her social work career in child welfare and then moved to the hospital setting, where she ultimately served as the Director of the Department of Patient and Family Resources from 1997 to 2011. Her experience includes individual counseling, management, clinical supervision, project management, and multidiscipline team leadership. Recognitions include the National Award for Excellence in Perinatal Social Work, Gainesville Social Worker of the Year, and the Florida Social Work Healthcare Leader of the Year. At Swanee River AHEC, she has worked with regional health and dental clinics, a homeless clinic, and community hospitals to ensure best practices with tobacco-using patients, including referrals and maintenance of tobacco cessation. I'll now turn this over to Kathy. Kathy?
Karen, and I think the only thing, thank you for that kind introduction, Karen. The only thing I might add is what you mentioned about working with the homeless, and I have to say that at this point in my career, that's my primary clinical interest, is working with the homeless and the near homeless to help them become tobacco-free. And thank you for inviting me to talk about this interesting topic, pharmacotherapy for tobacco cessation. First, I'll talk a little bit about our objectives, what we're going to do as we go through the presentation. I'll see if I can't shorten them a little bit. I'm going to describe the pharmacokinetics of nicotine and how that works in treating TB patients who use tobacco. Talk about types of non-prescription and prescription nicotine replacement therapy, products that people use successfully for tobacco cessation, and the types of non-nicotine pharmacotherapy, as well as being able to list 3 different tobacco cessation medication combinations that can be used to help in treating your patients who use tobacco. I've just been looking a little bit at the data about tobacco use worldwide and TB worldwide, and the numbers are fairly similar, over 1 billion. And we're not completely sure what the intersection is there, but we know that there is one, particularly in the developing world. So I appreciate your interest in tobacco cessation for your patients who have TB. We'll talk about the pharmacokinetics, which is how the body acts on nicotine or on other components of tobacco as well. So we need to start with a definition of nicotine. Nicotine is such an interesting chemical. In fact, it's been around for thousands of years. I think for thousands of years, indigenous people in the Americas recognized some chemical properties. And it was actually Christopher Columbus who took the tobacco plant to Europe, where they also began to use it in a variety of different ways. It's the family that tobacco is in is called Solanaceae, or some of you may know it as the deadly nightshade, because nicotine is a naturally occurring substance, and it's found in small traces in things like potatoes, eggplants, peppers, and other kinds of vegetables. But of course, it's primarily found in the tobacco plant. And one of its main qualities in the tobacco plant is as an insecticide. It protects the tobacco plant and others from being eaten by insects. But what's so interesting about it is that this natural insecticide, nicotine, its chemical signature is so similar to a neurotransmitter called the nicotinic acetylcholine receptor. You don't really have to remember that, since it's taken me quite some time just to be able to pronounce it. But the nicotine chemical signature is so similar in size and polarity that once it gets in the brain, that it fits all these kind of chemical locks so that it begins to directly and indirectly control the flow of more than 200 neurochemicals in our brains, most importantly, dopamine. And the dopamine pathways, which are the pathways used for all addictions, are important because they give us pleasure, but they serve as a kind of a built-in teacher. So say we get hungry or thirsty. So we know somehow and have known since birth that food is going to satisfy the hunger and water is going to satisfy the thirst. And as soon as we get the food, it's like, aha, until whatever it is kicks in and tells us we're full. Same thing happens with water. But what nicotine does to our brain is it so saturates these receptors that we think that nicotine is just as important as food or water. Now, I know I've heard and I've probably said in my life, I can't believe that person would spend money on cigarettes when they don't have enough to eat. And we're not going to feed them if they're going to buy cigarettes. But guess what? Their brains have been completely hijacked by this nicotine that mimics acetylcholine in our brains. It's alkaline also. It's kind of a weak base. We'll talk about that some more as we go on. But it exists in a liquid state. It's clear. It's volatile. Turns brown on exposure to air. And it's even what gives tobacco the kind of characteristic smell. So nicotine is absolutely what addicts people in all tobacco products. And the amount is not necessarily specified by the manufacturers. You wouldn't, or I wouldn't have believed it's so complicated how much nicotine is in each tobacco product. And it's even complicated as to how much nicotine is in the nicotine plant itself. It seems to get more concentrated in the tobacco plant, not the nicotine plant, the tobacco plant. But that's what we get from it, is nicotine. The closer you get to the top of the plant, and the closer the leaves are to the top of the plant, the more concentrated the nicotine is. And there's less nicotine in the leaves that are closer to the ground and on the stalks. And there's actually even less nicotine in the stalks. And we test nicotine in products by machines. We use chromatography. But there's been some research that shows that what really matters about in terms of how much nicotine a person uses or makes available to them is how they use the products. Remember years ago when light cigarettes came out, we thought, oh, this is great. Smokers will do a lot less harm to themselves. Full disclosure, I myself, former smoker, smoked some kind of light cigarettes. But the dirty little secret there is what people do when they get a cigarette or any tobacco device that has less nicotine in it is they use it in such a way that their nicotine levels get to the level that their brain is craving, just like how much water you're craving, how much food you're craving. So we can change the concentration of nicotine. So what happens with nicotine? This is a tolerance is the primary sign of addiction. And that can happen with 3 cigarettes, but generally it happens with, guess how many? Tolerance. 20 cigarettes. See, the tobacco companies, they figured all this out. In fact, they are way ahead of us in tobacco treatment. So on average, it takes about 20 cigarettes to get the brain fully addicted, to get those nicotinic acetylcholine receptors saturated, and also they multiply. They increase in their density. The more nicotine you feed to those receptors, the more you have. Amazing. There also is a certain kind of toxicity, and I didn't actually understand this very well until I started doing the research for this presentation. And then yesterday, a woman in one of my groups at the homeless center described to me quite spontaneously how one time she'd gotten really stressed out and she took a pack of cigarettes and smoked all 20 of them in less than 2 hours, and she got really nauseated and began to throw up. And she was using this image as something that would help her quit. But there's absolutely such a thing as nicotine poisoning. The other things that we know nicotine does, what we in tobacco say about nicotine is it's the nicotine that addicts you, it's the tobacco that kills you. And that's actually true, but nicotine doesn't get a pass completely because it increases the heart rate and it increases blood pressure. It is a vasoconstrictor. That's why as we get a little farther along and talk about some of the nicotine products, we'll talk about their use in relation to recent myocardial infarctions and heart issues. So the pharmacokinetics have to do with how the body acts on the drug. One of the things related to that is absorption. Our bodies can absorb medications and drugs and all kinds of chemicals at different rates, and very often they are based on other chemicals that we have in our bodies, but they're also just related to our own genetic predispositions. Absorption can happen so quickly with smoked tobacco. It crosses the blood-brain barrier within, I don't know, 10 or 20 seconds. And the other thing about absorption is the alkalinity. I'm not sure if I mentioned that earlier, but nicotine and both tobacco are a weak base, and so the alkalinity versus acidity definitely plays a part in the absorption. And whether it's ionized or non-ionized. I'm not going to get into the weeds and explain that in great detail, but I will say that if it's non-ionized, we're more readily able to absorb it, the nicotine, the tobacco, our bodies are. And when tobacco smoke reaches the small airways and the alveoli, the nicotine is really rapidly absorbed because there's kind of a large surface area there, relatively speaking, in terms of the alveoli, and that is, of course, where the gas exchange takes place, and the tobacco and the nicotine is able to get to the brain so quickly. And concentrations of nicotine in the blood, they rise quickly during smoking, and then they peak at its completion. And later on, we'll see a chart that I'll refer to a lot. It's a line graph that will show us how quickly certain kinds of tobacco gets into our brain and how slowly others do. The cigarette is really a perfect nicotine delivery device in terms of time and absorption. And the nicotine replacement products that we'll talk about, they enter the bloodstream much more slowly and by a completely different route. And smokeless tobacco enters more or less through the same route, but we'll definitely talk about that absorption that happens through the mucus or the buccal membranes in the mouth. That's the venal transmission as opposed to the arterial with the smoke. The distribution also is critical to understand when you're talking to patients about their tobacco use and about products that they might be able to use, that the tissues rapidly uptake nicotine once it's inhaled, and some tissues are much more sensitive than others, with the lung tissue being absolutely the most sensitive, and I believe the adipose tissue is the least sensitive. But the distribution pretty much goes from head to toe because it gets into the bloodstream. Nicotine also accumulates in breast milk. We'll talk about products for tobacco cessation, but I'll go ahead and tell you now that they are never recommended for pregnant women, and the nicotine crosses the placental barrier very easily. So if any of you happen to have pregnant women on your patient load, or pregnant women who are perhaps living with some of your patients who are smokers, this is something that's important to know. So inhaling, as I think I mentioned, really delivers it the most rapidly to the pulmonary venous circulation. Then it goes to the left ventricle of the heart, and then to the systemic arterial circulation and brain. And it's that arterial circulation that distributes it so quickly. And there's the 10 to 20 seconds with the perfect delivery system of the cigarette. Primary metabolites that we actually use these to determine the tobacco use. One of them is cotinine, and the other one is called nicotine N oxide. There's a lot less of that that's excreted in the urine than the cotinine. I don't know what kinds of tests you use in your practice to determine the tobacco use or the nicotine concentration that your patients are using. You can test either the carbon monoxide in the bloodstream with a simple monitor, or you can do a urine test, which, as I understand it, is very inexpensive to test for cotinine. It's metabolized by the liver. Nicotine is, although the lung does metabolize some of it, but the urine is the place where we test for nicotine. It's excreted by the glomerular filtration and tubular secretion within the kidney, and the pH flow rates affect the reabsorption of nicotine. And the half-life of nicotine is about 2 hours. And anyone who's ever been a smoker or knows a smoker understands that 2-hour window. People who are regular smokers pretty much get that wanting, that craving every 2 hours after they smoke a cigarette. The only thing I'd like to say here that I'll emphasize as we go on also is that people who use tobacco actually have a pretty good understanding of their own level of nicotine need. If you allow them to talk about that, they'll be your best source of information about dosing. I know most of you are not prescribers, but I think that you can provide a lot of really useful information to the physicians or providers in your practice. Pharmacodynamics are how the drug acts on the body, a little different from the pharmacokinetics. So the dose-response relationship is part of that, and the level of tolerance for a particular substance is part of that. Here are the more of the pharmacokinetic interactions. Caffeine is a big one, and it's probably the best one used to explain the pharmacokinetics here. Your patients are in all likelihood on any number of medications, and if your patient is a tobacco user, the current titration of those medications in all likelihood is based on their smoking status. So when you have a patient who wants to give up tobacco, give up smoking, it's important to consider the medications that they're taking and the current dosages.
it's actually less the nicotine and more the smoke, or technically speaking, it's the polycystic aromatic hydrocarbons from tobacco smoke that are the culprits here in changing the need for these dosages. So quitting may very well increase the concentration of these medicines, and I'm including caffeine as a medicine, as well as theophylline and Theodure, a bronchodilator that some of your patients may be on, insulin, of course, and warfarin. Those are Coumadin. Those are some really big ones to look out for when your patients are thinking about giving up tobacco. And then blood pressure and antidepressant meds may also be affected. So what happens with coffee? I'll just give you an example of this. Say you have a patient who drinks, let's say, 5 cups of coffee a day, and she or he decides, tomorrow I'm giving it up. No more tobacco. But they don't give up their coffee. So they still have the 5 cups of coffee. Well, for a lot of them, it's going to feel like 10 cups of coffee, and they're going to be really wired because of that concentration. And that's something to talk to your patients about, but also, more importantly, with these other medicines. And I think insulin and warfarin are really the big two to think about with your providers in terms of whether and how much they may need to change the dosages. Because if the person quits smoking overnight, it can happen really quick. If they don't cut down, if they just decide, today's the day, tomorrow's the day, I'm giving it up completely, it's really going to change their needs for these medicines. And they could have what we call supra-therapeutic levels, which means levels higher than necessary to treat their diabetes or their coagulation problems, and those can have side effects. And here are some other medicines to think about that your patients may or may not be using. Clozapine, Clozaril, olanzapine, these are some psychotropic medications here. That's known as Zyprexa, fluvoxamine, Luvox, Tacprine, Cognex. If you have patients among your TB patients who are using any of these psychotropic antidepressants, anti-anxiety meds, those are also some things to think about, changing the concentrations. And of course, the inhaled corticosteroids, the need for those is going to change. I work with a lot of smokers who already have COPD in my homeless clinic and are using inhalers. And whenever they quit smoking, all of them mention to me, because this is within their control, that they use their inhalers less. And then the hormonal contraceptives, I think we've known for a long time about the connection between tobacco use and using birth control or HRT, and this is something that can also be monitored fairly closely. And beta blockers could also be less effective. And another thing with smoking is that benzodiazepines and central nervous depressants could also be medications that patients would need less of after they stop smoking, because nicotine is also a bit of a stimulant, so it contradicts or it counteracts medications that are central nervous system depressants, like the benzodiazepines. Now with TB drugs, there's definitely been some research, but the outcomes have not been as dramatic, say, as needs for insulin and Coumadin. Bupropion, which I'll talk more about later, that's a non-nicotine replacement drug, it may have an interaction with linezolid, but that's just something for your providers to pay attention to if that's a drug they want to prescribe to help the patient give up tobacco.
and cycloserine and bupropion. Bupropion is also known as Zyban and Wellbutrin. When we talk about it in the tobacco world, it's called Zyban, but it's often called Wellbutrin when it's prescribed as an antidepressant. But since both of those can cause seizures, if you have a patient on cycloserine, you really might want to monitor them for their seizure activity, and there's also a potential interaction with the quinolones. But overall, smoking cessation products have been used with TB patients without any big issues, so a good thing to know. This is the addiction cycle. The biological is a lot of what we've been talking about so far, and then there's the cultural. That's people living in communities where smoking is the norm, living in households, or even in institutions, drug treatment facilities. I'm told they're getting better. Nonetheless, there's still quite a bit of tobacco use that goes on in facilities for other drug treatment. So those are places where it's the cultural norm to smoke, and those are tough. However, they really are dwarfed by the psychological. The psychological addiction is really the biggest hurdle to conquer. And that's one of the reasons the way you talk to your patients is important. It's important to use motivational interviewing when you can and get them to talk to you about their own motivation and their own triggers and how they'll get beyond those. Because you can prescribe them medications and they can perhaps stop going to the bar where people smoke, but the psychological, the triggers that are in their everyday lives, that's going to be the toughest thing to overcome. Here are some of the physical withdrawal symptoms: tingling, hands and feet, sweating, nausea, headaches, coughing, sore throat, insomnia, difficulty concentrating, irritability, weight gain, and the list goes on and on. Anxiety, depression, you name it. It's a horrible thing, this addiction is, and the withdrawal is really severe. And it varies. Everybody is different, going back to the pharmacokinetics. So some people will be able to get through the physical withdrawal much more easily than others. So here's a little table, kind of gives you an idea of how withdrawal goes. So what's typical, in the first 4 hours in, that's right after your last cigarette, 4 hours later, the body's asking you, I mean, sometimes it's 2 hours, like we talked about for the heavy smoker, but for sure, by the time they get to 4 hours. Some people can take a deep breath and get to 3, get to 4, but by the time they get to 4, they're definitely going to have cravings. When the body is asking, why haven't you gone out for a cigarette? So the thing to do then is just distract. Get yourself to do something else. Distract, drink water, whatever can get you past that craving, because it will go away within a matter of minutes. 10 hours in, though, that'll be a tough one, too. There'll be restlessness, and that's when the insomnia may kick in, when your patient is trying to sleep. So a good thing to do here is to talk about a new bedtime routine. Sleep in a different place, get in the bed on the other side, anything that just changes things up, because the brain, remember, has been hijacked. So what we need our patients to do is work on getting their brain back, getting back to their pre-hijacked brain, if they can remember it, and most people can, when they could sleep, for example. So next is one day in. What's going to be hard a day in is mornings, because so many heavy smokers, when they have that first cigarette, is when they put their feet on the ground, or maybe even before. I've had people tell me that was their first trigger, putting their feet on the ground. And for many of our tobacco users, that is the most important one. So it's no small thing. So what we say is remind yourself you're irritable and you can be irrational from quitting. And explain it to everybody. Tell everybody you're going to quit. Say, you thought, I was in a bad mood in the morning before. Wait until you see me without my cigarette in the morning. So at 2 days in, then the headaches can kick in. But 2 days is not bad because you're getting really through the worst of it. But 2.5 days, anxiety, more stress. We need to keep telling our patients to exercise and to breathe deeply, and maybe even back to that morning, drink less coffee, switch to tea, change it up. But now 3 days, that's a marker. In general, and nothing is the same with everything, but in general, 72 hours it's going to peak. The withdrawal symptoms are going to peak at 72 hours. At that point, your patient should get some relief from the craving. What we don't want to happen then is for them to cave into peer pressure. At 72 hours, we want our patients to say, I'm done. Not one more puff. Not one more cigarette, not even a puff. Because when you get to a week, in terms of the physical withdrawal, just about everybody is home free. Then it's going to be a slip or a relapse and all of those psychological triggers that play into it. They all tell me stress is the biggest one. So how can we help our patients? There's been lots of research, lots of new medications and techniques on the market, but today we're talking about how can we help our patients with the pharmacy. One thing I do want to say about nicotine replacement before I even get into the details is that you may be worried about how your patients are going to access nicotine replacement therapy, the things that are over-the-counter yet very expensive. We have a really robust program in Florida from the tobacco settlements in 1996. I know you're all from different states and you may have different programs, but every state got tobacco settlement money and has a quit line. And if your patients call 1-800-QUIT-NOW, if you call 1-800-QUIT-NOW, they'll hook you up with your state's tobacco program. They'll send you materials that you can put in your offices, and they'll give you the direct quit line in your state. So if you don't have nicotine replacements on hand, or if your patient's insurance won't pay for them for some reason, tell them to call this number. They'll get free counseling and free products one way or another. So here are some of these products. There are 7 according to the Clinical Practice Guidelines, which came out in 2008. And if any of you heard my last webinar, I talked about those, and that's still what we go by for the most part. We look at the new research, we look at the Surgeon General's report, but that handbook still covers almost all of what we do. And so there are still these 7 first-line medications available. They are the ones determined by research to be the most effective and to have the least deleterious side effects. So the ones you can get with prescription only, and I'll talk about these one by one, are what we call the nicotine inhaler. It's a bit of a misnomer because we're not going to have anybody breathing it into their lungs, but that's its brand name. That's what Pfizer called it. Nicotine nasal spray, Bupropion SR, which is also, that means a sustained release, also known as Wellbutrin and Zyban. Varenicline, also popularly known by its brand name, Chantix. So the over-the-counter drugs, what people can walk into the drugstore and buy, are the patches, the gum, and the lozenges. And they're what most quit lines, or at least the gum and the patches, will send your patients for free. I don't know how much they send in every single state, but it'll be anywhere between 2 and 8 weeks. Probably a 2-week supply at a time, and then another supply and another supply until your state gets to what its maximum is for the year. Nicotine replacement's been around for a while. 1984 is when we first saw the gum. Just missed my quit date. So the 2 milligram gum came on the market then. And in 1992, we began to see the prescription patch. That was approved. In 1993, we saw the prescription 4 milligram gum was approved. And in 96, both of them got approved for over-the-counter use, which I have learned, and you may know this, is a really big deal. It takes years to get a product from prescription status to over-the-counter status, and according to GlaxoSmithKline, who makes the brand name products, it takes about 5 years and billions in expenditures. So they did that. Fortunately, in 96, the nicotine gum and patches were approved for over-the-counter use. In 1998, the nicotine vapor inhaler, or the puffer as we call it, and we'll talk more about it, was approved. But it was approved for prescription use. And just through the fact that from 96 to 98, there was a time lag between the approval of the gum and the patches and the inhaler. So the drug company has determined, and I think this is forever, that it's too expensive to bring the inhaler or the puffer to over-the-counter status, and thus it will never have the popularity, even though it's a very good product for a lot of reasons, that the gum, the lozenge, and the patches do. So in 2002, over-the-counter nicotine lozenges got approved, and lozenges are a great alternative to gum, especially for people with dental issues and false teeth, and I'll talk more about that. So in terms of the non-nicotine products, the Bupropion or the Zyban was the first non-smoking cessation aid to be approved by the FDA, and that's 1997. And the Varenicline, that was approved in 2006. But interestingly enough, for both of those non-nicotine products, they both got a black box warning in 2009. And since you're all in healthcare, I assume you know what a black box warning is, something that gets your attention and you're less likely to use it. And in both of these, it was because of psychiatric issues. But the good news for these products and for tobacco users who want to quit is, after much research, the black box warning was removed from both of those in 2016. So they're good products. They're prescription, and thus, of course, they need to be monitored carefully, but there's good evidence that they work. And this is how much they cost. The cheapest one, I think, is the generic gum. And the most expensive, of course, is the Varenicline. It's the newest drug, it's prescription only, and it is quite expensive, and thus often, and I might even say often not even covered by insurance, which is a sad state of affairs. So the 2013 average cost of a pack of cigarettes was about $6, and I know that's going to vary from state to state. If some of you are in Michigan or New York, where the cigarette taxes, the sin tax as they call it, are high, they may be over $10 a pack or even more than that. The good thing about that is that in those states where they have a high tax and cigarettes cost a lot per pack, your overall tobacco use rate is absolutely lower. And I'll get back to that $5.98 because the tobacco companies and various other entrepreneurs have found a loophole so that addicted nicotine addicts can access tobacco much more cheaply than $5.98 if they're not brand particular. Here's a very nice chart. I won't necessarily go into it. except to mention the amount of nicotine, because I believe you have a copy of this in your handout, or you'll get it as a PDF, that the amount of nicotine in a regular cigarette is maybe 1 to 1.8 milligrams, is that right? I can't see it from here. But when you get to cigars, the milligram of nicotine, and this doesn't have tar, but tar as well, is also much higher. So let's remember cigars, especially little cigars. So why would we do this with our patients? Shouldn't they just quit cold turkey? And the truth is, most people do quit cold turkey. It just takes them a lot longer, and they've done a lot more damage to their bodies. And our Department of Health, and I'm sure your state Department of Health, worked long and hard in your American Cancer Society and your professional organizations to help those of us in tobacco treatment and advocacy and prevention get dollars to go toward helping our patients quit, helping them quit sooner. So pharmacologic options, they do that. They make it easier for a patient to quit, plain and simple. In fact, we know from the research, and all of our research, I tell my patients, we know from working with tobacco users, we learn this from you the tobacco user, is that if you add a product, whether it's nicotine replacement or a prescription, if you add that to your quit attempt with counseling, your chance of succeeding is doubled. Who wouldn't take that? Who of the 70% who want to quit wouldn't take that? And the World Health Organization has added it to its list, nicotine replacement of essential medicines. So why use it? Again, it works. It reduces the severity of withdrawal. You remember what we said about withdrawal. It's just terrible. But you can really mitigate those symptoms very well by using NRT. We want our patients to be more comfortable. And your TB patients, they really need to take extra special care of themselves given their disease. And it's safe. What we say is it's clean nicotine. Clean nicotine versus dirty nicotine. They're not inhaling burned organic materials into their lungs and getting those polycystic aromatic hydrocarbons from any of the products. But nothing is completely without risk. If you have a patient who's had a recent MI, I think 2 weeks is considered recent, they have unstable angina, they're pregnant, under 18, or they're on an MAO inhibitor, and you want to give them bupropion, and you need to look really closely at the medicines they're already taking. If you have patients with clear psychiatric illnesses, especially if they're on psychotropic meds, you want to talk to the provider and take that into consideration. And you as nurses, which I think most of you are in a really good position to talk to your providers about that. And Varenicline is metabolized through the kidneys, so it's there's some limitation suggested when using it with patients who have kidney disease. So here's a great visual for the concentration of nicotine in the tobacco products and in the non-nicotine replacement products. Remember I told you cigarette's the perfect nicotine delivery device? Look at it up there. Gets to the brain in, what's that look like, about 10 seconds, and delivers a maximum amount of nicotine. And then down there at the bottom, I think that blue line is the patch because that's transdermal. We'll talk about that. Gets in a little more slowly and stays there, at least for 24 hours. But I would draw your attention to moist snuff, dippers, smokeless tobacco. They have the hardest time quitting, and honestly, we don't have really good evidence about how best to help them. We try to help them with whatever tools we have, but it's very difficult because you can see it goes in slowly and the nicotine level gets up really high and it just stays there for a very long time, sitting in their mouth, getting through the buccal membrane. But the clean nicotine, you can see it delivers much less nicotine and without any of the hydrocarbons. Here's a dosing chart. You also have that as a PDF. Just gives you very specific instructions on dosing. We'll talk about that. But it is it's for informational purposes. I would refer you to the handouts inside of the product or professional publications for dosing, but it's a very good guide. And again, it's all use of all of these products cautioned in pregnant women, although I know obstetricians who have made the decision, as they can, that the patch or the gum would be better for their patient than the amount of tobacco smoke that they were inhaling on a daily basis. So that's individual. Again, the unstable angina and persons under the age of 18. Our State Department of Health regulations don't allow us to provide people under the age of 18 with nicotine products. And as a result, there's been very little research done. So here's the dosage. The Nicoderm patch comes in 21 milligrams, 14 milligrams, and 7 milligrams. And should be greater than 21 milligrams. There's been much discussion and research about using more than 21 milligrams with heavily addicted smokers and perhaps with those who use smokeless tobacco. So talk to your providers about it, because again, tobacco users know. And if a 21 milligram patch is not strong enough, they'll know. They'll have a lot of breakthrough urges. And if it's too strong, if the 21 milligram patch is too strong, if you look at the dosing, they'll know that also. They might have a little bit of nausea, but my patients tell me. Use the guidelines by all means, but understand that the tobacco user, him or herself, is the person to give you the best feedback. And this is kind of how we do it. If you smoke more than 10 cigarettes a day, we suggest 21 milligrams, 4 to 6 weeks, then titrating down to the 14 milligram patch for 2 to 4 weeks, the 7 milligram for 2 to 4 weeks. And if you smoke for light smokers, you start with the 14 for 6 weeks and then move to the 7 milligram for 2 weeks. This is all in the package and on your chart. What I would say from my personal experience with this is that it almost always, especially with my homeless and near homeless population, takes much longer than this. And I think you'll find that the research supports that as well. But those are the directions for use of the patch. This is how you use it: clean, dry, hairless skin. If you're homeless, I give them alcohol wipes. Patch every 24 hours. Put it on different parts of the body. The patch is great. The reason that it fails usually is that it is improper use. Don't cut it, for goodness sake. Get a different size. And skin irritation is the adhesive, not the nicotine. There are all kinds of things you can do to mitigate against that as well. Put antibiotic cream underneath it, put it on with tape, use it if possible. Some people have vivid dreams. In fact, yesterday at the homeless clinic, one fellow told me, he was talking to somebody else, he said, "Did you have the dreams?" And she said, "No." And he said, "I did. I liked them." I like those vivid dreams. So again, everybody's different. Talk to your patients. And if you don't like the dreams, take it off before you go to bed. I have people who do that. And there's the cortisone cream or spray you can use. And of course, wouldn't work that well with eczema or severe skin disorders. The gum's been around for a long time. There are 2 strengths, 2 milligrams, 4 milligrams. If you have the first cigarette within 30 minutes of waking up, use the 4. If not, use the 2. And you can use it a piece every 2 hours, up to 24 pieces, I believe. I've actually never known anyone who used quite that much, but if you look at the directions, that's what it says. And that's what it says in the guidelines. The gum is not for everybody. These are some of the adverse reactions people can have. Important thing to know, if you've got somebody on gum, don't chew it like regular gum. You don't want to keep it, you want to move it around. You don't want to keep it in one place. You don't want the jaw ache. And if people chew it like regular gum, not only will it exacerbate an ulcer, but it'll get down there and the stomach acid will kill the nicotine, so it won't do its job. And can't use it if you have TMJ or dentures or various other dental appliances. And here's a little chart that may be useful to you in terms of just telling people how to use the gum. Chew it slowly, break it apart. Within a minute or two, the patient will feel the tingling sensation, and then move it to another part of the mouth. You can do that for about 30 minutes. I have people who keep chewing it after the 30 minutes just because it gives them something to do, but you're not getting any more nicotine after 30 minutes. And here is the lozenge, a great product. Not all quit lines provide the lozenge. It comes both in the 2 and 4 milligram strength and the same dosing depending on how soon the person has their first cigarette. The lozenges are a great alternative for people who have dentures or dental problems, which many of our homeless and near homeless, and honestly many of our tobacco users do have severe dental problems, dental issues. Again, the directions, you want it to dissolve slowly, you feel that tingle, and you move it. You don't chew it. If you chew it and it goes down into the stomach acid kills it. And the directions for the gum and the lozenge are the same about not having acidic drinks like coffee, tea, soda, 15 minutes prior to or during the lozenge use. There could be some side effects, indigestion, hiccups. One of my participants was in the group talking about coffee as a trigger, and he said instead of smoking the cigarette, he just popped the lozenge in with his coffee. And another participant who's quite an alumni of the group, he proceeded to tell him this little rule here about not doing it. And I had to say, John, or whatever his name was, you know what? I never argue with success. If it's working for him, it's working for him. Okay, more about the prescription products. The nasal spray is a good product. I personally have never run into anyone who was using it. It may be the right thing for some of your patients. It does. You just need to know it has a higher dependence potential because of the concentration. I do know from literature, though, that everyone who uses it initially, you use it a lot like you use Flonase, but everyone who uses it initially gets some of these side effects, nose, throat, and eye irritation, and they get past it. Again, I know this from the literature, not from people who have used it. So the nicotine inhaler, a little known but very effective product. If you have patients with insurance for whom you can prescribe this, do it. Try it. If your patients want to quit, the 70%, try the nicotine inhaler. It's especially good for people who, and this was me as a tobacco user, the hand-to-mouth was really important. But it's not an inhaler again, it's a sipper. You just sip on it, and here's a little picture of it. It's got menthol in it, so if your patients are allergic to menthol, you don't want them to be using the inhaler. Bupropion, also known as Zyban or Wellbutrin. They discovered quite by accident when prescribing this as an antidepressant that it also decreased the craving for cigarettes. So it may be that for some of your patients who have depression as well as a bad tobacco habit, this would be the right product. Remember the contraindications. This one is not within 14 days of discontinuing an MAO inhibitor. Bupropion can lower the seizure threshold. And think about those psychiatric symptoms. Even though the black box warning was taken off, it's just something to monitor in your patients. That says Bupropion SR, which means not slow release, but sustained release. There are three kinds of bupropion. There's single release, sustained release, and there's a new one now that's extra release. Those patients using that would only have to take it once a day. The guidelines always talk about bupropion sustained release. And so that has to do with the dosing. And the dosing of this medication is very important. That'll be on your chart as well, and because it's begun 3 to 7 days prior to quitting, and then it is increased from the 150 milligrams once a day for the first week, and then twice a day for the second week. Again, contraindicated to anybody with seizure disorders or an eating disorder because it has some appetite suppressing effects. Bupropion does. Varenicline, the newest drug we have, we've talked about it a little bit. It also has very specific dosing instructions. You begin it a week before your quit date. Here's a starter pack, gives you specific instructions on how to increase the dosage and when to take it. And always take it with food or water. The most common side effect with Varenicline that I have heard from my patients is nausea. It's fascinating the way that it works. I'm not sure I have time to go into the fact that it's a partial agonist, and so it binds to that same receptor that the nicotine binds to, but it doesn't bind completely, and it binds before the nicotine does, so you could also be smoking with it, and it releases, this is the key, less dopamine. And the less dopamine that gets released, the less high or good you feel after that satisfaction. So it's a really good product for that reason. Diminishes the withdrawal symptoms. It's approved by the FDA for monotherapy. I've seen some research about using the patch with Varenicline. There's very few studies. Some say no effect, and there's one that had a really good effect. So again, this is something to talk to your providers about for people who are heavily addicted. Like I said, nausea, I think the worst side effect, but certainly not the only one. Some people have been allergic to it, and you want to look at psychiatric symptoms, particularly suicide. 2009, that's when the black box warning went on. GlaxoSmithKline let us know that the reason the black box warning went on after they did 5 years of research is because they had some single phone calls after it went to market about suicidal ideation and perhaps even completion, but that was not research-based. So they spent between 2009 and 2016 trying to replicate that and find out if they could, and they did not. The benefits still outweigh the risks. What was called the EAGLE study, published in the Lancet in 2016, an enormous study. So again, the benefits outweigh the burdens and the symptoms. Nonetheless, I don't want to downplay how important it is to look for those psychiatric symptoms in any of your patients who may be on Chantix. Combination therapy. That's kind of our last bullet point here. Combination therapy, according to the guidelines and all of the latest research, is the way to go. Hardly any researchers or tobacco treatment specialists recommend single therapy. You have to individualize it to your patient. When you have a motivated patient, always consider combination therapy. Whether it's the patch and the gum, those are easy. The patch and the lozenge, those are easy. See if you can't add counseling, because that also
increases the chances of success. The patch and bupropion, that was even in the 2008 guidelines. And the patch and the inhaler. Those are all FDA approved. Other tobacco, as I said, very little research about helping smokeless tobaccos quit. What we've learned about smokeless tobacco users, we've learned in our own groups. Very often it's the lozenge that they use, and again, they know how much they need. The patch and the lozenge and ongoing counseling, we have groups that are 6 weeks long. They can do telephone counseling because it's a really, really tough tobacco habit to beat, smokeless tobacco, and it's concentrated in poor and rural areas. I don't know how, and in the South actually. I don't know how many of you on the call are from the South, but here in Florida, in our poor rural areas, we have a really high rate of this, as much as 7 or 8%. So this just talks about how much they use and how much you might want to dose them with based on how much a smokeless tobacco user uses. Often I would go for or talk to the provider about using more than a 21 milligram. 42 milligrams is good because that's simple. It's just 2 patches. But remember that chart, how high the nicotine level goes and how long it stays there for the smokeless tobacco user. Cigars. I talked about cigars. The little cigar here is the culprit. The tobacco companies made sure that the regulations related to taxation said cigarette. So what they did is they took the definition of a cigar, which used to be tobacco wrapped in a cigar leaf, and they changed it or updated it to paper that contains tobacco. And thus we came up with the little cigar. Very different from the big cigar there. Here's some recommendations for dosage based on a big cigar, using a big cigar, which are generally not even inhaled, versus at the bottom you see the little cigar, which are treated, as far as I know, by our patients just like cigarettes. They're clippers, 305s, black and milds. They're all cigars. They're not taxed. Here, you're lucky if they're as much as $1.50 a pack. That's 20 little cigars for $1.50. One of my current patients smokes 3 packs of these a day. So you're going to need to dose your patients more heavily if they're using these little cigars, and remember that many of your patients are, so make sure you ask. We like the 42 milligram patch for someone who's using 2 or 3 packs a day, even 1 pack a day, because some of the research on how much nicotine is in there is 4 times as much. 4 times as much. So go for combinations with your heavy tobacco users. Combination, whatever it is, individualize the combination therapy for your patient. Your patient is the one who knows exactly how much nicotine he or she is using, and they will know how much they need. What I tell my patients who have relapsed is that relapse is part of recovery, and in fact, don't think of it as failure, think of it as practice. You're going to be better at doing this the next time. And there's no shame in it because, as we said at the beginning, your brain has been hijacked into thinking that you need nicotine just as much as you need food and water and other basic needs. Again, here are the combinations suggested. There's not enough research yet to support using NRT with Varenicline, but I think that within the next few years we'll see that. Need to know the 3 names of Wellbutrin, Bupropion, and Zyban. So this is reinforcing a lot of the things that we've talked about. How you find out what's best for your patient. Just kind of the take-home message for you. Know what medicines they're on. Let them tell you about their past attempts, what worked and what didn't. And certainly you know how sick they are. See how open they are to trying new things. How easy is it for them to use?
just a little research that shows you that people are pretty compliant with the patch. A little less compliant with the nasal spray and the inhaler. A patch is easy. Give them something that's easy. For some people, a pill is easy. Learn that about your patient. Just a moment here to say one last thing about nicotine replacement and how long a patient can use it. I tend not to worry about that. Nicotine is certainly bad for your patients. It doesn't get a pass, but it's clean nicotine versus dirty nicotine. An oncologist at MD Anderson told us, and at a workshop not long ago, told us in tobacco treatment, he didn't care how long his patients used the gum or the patch, as long as they weren't smoking. Now, that's not approved, certainly by the FDA or the clinical practice guidelines. I'm just repeating what the oncologist said. But studies show that 26 weeks of counseling and nicotine replacement gets you the same results as 26 weeks of Chantix. May be hard for some of our patients to get that much therapy, but if we can help them, we need to.
And then we just wanted to mention our last webinar in this series will be on September 5th, and that will be talking about treating tobacco dependence in special populations, and that's going over populations of people who might have HIV or diabetes or the homeless population, a lot of those people that you tend to work with when you go out into the field. So with that, we know we're over, but we will go ahead and take questions. I see some in the chat.
Hi, Kathy. This is Karen. We have a question. There's a question about NRT, specifically the patch. And the question is, why is cutting a patch in half or in quarters contraindicated? Couldn't it reduce patient costs if you did that?
Boy, that is a great question. But what I have read about cutting it is that then the nicotine and the adhesive begin to leak out, and that you no longer have the integrity, because the nicotine is in the middle of the patch, and if you cut it, then it begins to ooze onto the skin in a way that is not useful and in a way that doesn't let you know how much you actually have. But it is a great question, and I certainly understand that.
Thanks, Kathy. And then there's one more question from our friend in Greece. Is there any experience of e-cigarettes and cessation for our TB patients specifically? Is there a difference in terms of the recommendations for NRT or quitting e-cigarettes?
Well, I have not seen research related to TB patients and e-cigarettes. Certainly there has been a bit of research done now on e-cigarettes and quitting, and the results are mixed. One of the problems is that e-cigarettes are currently not regulated by the FDA, although the FDA did take them under its umbrella, I believe, last May. But the regulations that were supposed to go into place in 2020, I think, have now been put off for 5 years total. So I don't know when they'll be regulated so that a user will know exactly how much nicotine they're getting in the cartridge or whatever form of the e-cigarette that they're using. So part of the problem is not when you buy it, not knowing how much nicotine or whatever else for that matter is in the e-cigarette. Again, I have people who approach me and tell me they've been successful using the e-cigarette, and as I say, I never argue with success. I'm a little worried about the kinds of droplets of propylene glycol and glycerin that you're heating up or burning and inhaling into your lungs in droplet form, since we've never taken those chemicals into our bodies in that way before. That would concern me.
Thanks, Kathy, and thanks so much for all of the content that you provided on pharmacokinetics, pharmacodynamics, and the NRT options. Very much
My pleasure,
appreciated.
Karen. My pleasure.
And to everyone who joined us today, thank you.